Good afternoon, everybody. This is the Cancer Tier 1, Tier 2 cohort webinar. Thank you for attending. The webinar is being recorded. I would like to present the educators for today. We have Dr. Bumi Olajide and Dr. Sangeeta Pashanasamy, and Senior Health and Wellbeing Coach, Jiga here.
Yeah.
Please, can I ask that you all mute yourselves? I know most of you have. All right. I'll just start to share the slides and go through a little bit of housekeeping. Do use the Zoom chat if you have any questions that come to you during the presentation, and we'll get into them in the end when everybody has finished presenting. We will definitely be sending to you on the Zoom chat before we close this meeting a feedback survey so that you could tell us what you thought. When you complete this feedback, you'll get a certificate of attendance. And as always, this webinar is being recorded and it will be up on our site within 2 to 4 working days. I will now hand over to Dr. Sangeeta Pashanasamy. Thank you.
Thank you, Yasmina. Good afternoon, everyone. I'm a GP at Clay Hall Clinic. And today I'm going to talk about something that's very relevant for this audience here, which is the cancer care reviews. We were just chatting before this one, and we realized that this year has come to an end, and a new financial year is starting, and some of the targets might change, but the cancer care review has carried on. There are, as well as maintaining a register for patients with cancer, there is an expectation that primary care offers cancer care reviews at 2 touch points during a patient's journey with cancer, which is at 3 months, where there is more of a diagnosis and initial treatment is happening for patients, and we offer a cancer care review at that time, and one at the end of the treatment, most likely, which would be around 12 months. Most of the patients would have completed their treatment. These are the 2 most vulnerable times in patients' life, and I think the cancer care review can make a huge difference to how we care for these people. Next slide, please, Yasmina. Thank you. So I feel very passionately about cancer care review, and I'll tell you why. I've done cancer care reviews for many years, but more recently, I did a workshop for women surviving breast and endometrial cancer at Maggie Center at Barts Hospital. And, so people were talking about their challenges, fatigue, not feeling themselves. They had hoped that when they completed their treatment, they'll bounce back to who they were. But the reality was very, very different. And they talked about, there was a number of questions they were asking me, just like, I'm fatigued. Should I be getting my thyroid checked? Should I be getting my vitamin D checked? I turned around and asked them, so what happened during your cancer care reviews? Did you not discuss your symptoms with your GP? And you won't believe 6 of the people in that group said they have not heard about cancer care review. They were not offered any information. They actually didn't feel that we in primary care had been part of their cancer journey at all, which really sort of made me feel a bit sad and made me think that, God, we should do more than what we're doing currently. This is kind of reflected in our National Cancer Care Survey results as well. This is a survey result from 2022. And the respondents said that just over half of them actually did not understand what the long-term side effects of their cancer treatment was going to be and how it was going to impact their day-to-day life. And just under half of them also said that they did not get adequate support from the GP practice. So, we really need to sit up and take notice of this and start thinking about ways of doing our cancer care reviews better. Next slide, please. So this is what the expectation of a cancer care review is. It's not just physical problems, it's not just emotional, it's everything. It's a holistic conversation, a chance to have a conversation with your patient. And the overwhelming objective is really to give them information, offer them support, signpost them to the right resource so patients can self-manage, or people who are supporting them can self-manage. That's the whole idea behind our cancer care review. And the I'm sure most of you in this room have done cancer care review, and patients' needs are quite complex. And if anyone thinks that only clinician can do a review, or social prescriber, care coordinator, it's not true. It's an MDT approach, and it's really, really important, whichever practice you're working in, that when you have these complex patients and their needs are not met, that you actually bring it to MDT or a practice meeting and have a discussion about this. And I would encourage you to start thinking about letting your practices know that that should be an agenda, a recurring agenda in the practice meeting to discuss these patients. Next slide, please. Now, I strongly believe that processes and systems in general practice, or any system we're working in, should be reviewed and improved. And more, I know that ARRS roles, social prescribers and care coordinators and other team, you've been around for quite some time, and you are very much a part of the team. So it's our responsibility to sort of try and look at how practices are organizing these cancer care reviews and feedback to them to say how you can improve this. For me, what was jarring was that none of them actually knew, the patients, been on the cancer journey, actually knew what the goal of a cancer. Well, many of them did not have cancer care reviews in the first place, and those ones who actually did have a cancer care review, they didn't quite really know why they were there. What kind of support was being offered to them. So, the cancer care review actually starts with how we invite the patients into the practice for a review. So, is it a phone call? If it is a phone call, do the staff know what to tell the patients to expect when they come for the cancer care review? If it is an AccuRx message you're sending out, do we have something that actually tells them what to expect? Or are we just sending out a letter to patients? So how are you inviting them? What is good for these patients? Just remember that in the first 3 months, they're overwhelmed. They are going from one appointment to another. If it's a breast cancer, they go to the surgeons, then they go to the oncologist, then they go to a different place for radiotherapy, and they're having to take huge amounts of information and make life-changing decisions. It's a very difficult time for them. So it can't be only face-to-face, or it can't be only telephone. I think when you offer appointments, it should be what suits the patients the best. And the practice really needs to think about giving adequate time for the healthcare professional to do a good review, and is it going to the right person in the team? So a little bit of thought has to go into this. And you, as the frontline clinicians doing the cancer care review, if you feel differently, you need to feed back to the practice so they can improve on their process. And also, as I said, it's an MDT approach. Should we get the non-clinicians to do the review first, identify the needs of the patients, and then feed back to the clinician? So, they do a slicker, quicker review, but the patients feel listened to, or is it the other way around? There isn't, I don't think there's one size fits all. It really comes down to the team, you and the clinician, who then decides, how you do the cancer care review. And also, the most important bit, I'm sure it's going to come up in the next slide, but I can't stress this enough, is cancer care reviews cannot be done just because there is a template and you fill the template. There has to be training and supervision, commitment from the clinicians in the practice, or clinician in the practice, for non-clinicians to be able to do an effective cancer care review. Next slide, please. So, as I said, templates are always helpful because it kind of reminds you about the various aspects that you need to cover. So, I would encourage people to use the templates, but one of the challenges of using templates, sometimes it just becomes a tick box exercise. So, just be mindful of that. But in the most important considerations for you when you do cancer care reviews, really understanding what the patient's diagnosis is, and just thinking about what treatment they've gone through and what sort of consequences that they're having or long-term effects it's having on them. Uh, patients and carers information is I've left that because that was what was flagged up when I did the support meeting, that people said that we didn't have enough information. On top of being overwhelmed with all the life-changing things that was happening to us, we had to be in our driver's seat looking for information, seeking support, and they found that very draining and they found that very demoralizing. So just remember that they would need lots of information, and it's really important that when we are giving them resources, like for example, if you're giving a Macmillan's website, I think we have the responsibility of sort of navigating through the website, trying and figuring out, if someone has got breast cancer, where's the right place for them to get the information. If they're going for an appointment, like they're going to go and discuss about radiotherapy, there are parts in the Macmillan's website which kind of tells you the questions to ask. Prepare yourself for the meeting. So just helping them to navigate the website and also understanding IT illiteracy, and Burma is going to talk about health inequalities in care, in caring for patients with cancer. So just being mindful of that and taking that little bit extra time to help them navigate through the resources available. There is a Macmillan Cancer Support Line. So, if patients are struggling, they can actually give a ring and someone will call them back. But most of us will know, but sometimes we don't, so it's really, really important that all of the support that we are telling patients, we have access to it ourselves so we can help them to navigate through those things. So obviously it's also emotional needs, financial needs. There's an expectation that we deal with diet and lifestyle advice for them, all the available local resources. Now, while I'm at this, I'm sure majority or almost all of you would know about Maggie Center, but having been there and seeing the amazing work they do, I want to plug them in. They do workshops, and one of the workshops I was most impressed by was What Now, which is a 6-week workshop they run for patients who are post-treatment going back into their normal life. But it's not normal for them. Everything has changed for them. It kind of eases them into that transition. And so, and it's a drop-in place. It's very friendly place, and there are always people around who are willing to talk to patients. So that's one resource because I was involved in it. But there might be so many other resources out there. And if I can ask the group, if you don't mind, if you have found a voluntary organization or a website or someone you spoke to, you found very, very helpful in supporting patients with cancer care review, could you please be generous and just put them in the chat so it will help other people as well. And surprisingly, I learn most from the patients themselves because they've suffered through the symptoms. They've been on this journey, and each of them had little tips and tricks that they had used to sort of navigate the journey. So just as an example, we were talking about hot flushes because people who go through hormone treatment, their hormone levels drop drastically, so their menopause symptoms are exaggerated 100 times over and above all the other things that are happening to them. We were talking about chiller pillows and how we can people can use that to support them. Someone said that those ones where you could just put them in the fridge and it cools like an iPad, or the eye patches, iPads, or whatever you use, and just putting in the upper body because your hot flushes tends to happen in the upper body. And she said she just puts it on her upper body and then sleeps. It just slips off, and she gets a peaceful night's sleep. And we were like, oh my God, that's such a simple, common sense solution. She had thought about it. Not many people would have thought about it, you see. So please be curious. Ask the patients about their challenges, but equally ask them how they have, just remember that they are resilient. Most of them are in the driver's seat of their health, and you can learn so much from them. And then that treasure trove of information you could then share with other patients. Next slide, please. So what are the considerations for the patients? And I'm just curious to know, I don't know if show of hands is possible here, but have you ever sent patient the concerns checklist before you did a cancer care review?
If I may suggest that you write in the chat if you have or haven't. That would be easier.
Sure.
Thank you.
I see few hands up. So essentially, it's a very comprehensive. Sorry, I didn't put it in the slide because it's too popular, but it's just a A4 piece, one side A4 piece of paper, and so we could share the information with you if you haven't used it. It's on the Macmillan's website, and it says concerns checklist for cancer care review. And essentially, it kind of helps patients to think through things. What are your physical concerns? What are the practical concerns you have in your life? What are the emotional concerns? Any relationship concerns? And when we were talking to this group of women, I just realized that how much they're struggling with intimacy and connection with their partners because life has changed and they are not the same people. And sometimes it's difficult for the partners to understand that. So just helping them to think about these things, even the spiritual needs, or it could just simply be, what am I supposed to eat now? How can I stop this cancer from happening again? So need for information. So um, something to think about. People who are using it consistently, well done you. People who are not, please have a look at this and see if you can incorporate this in your cancer care review. And my suggestion would be to send them beforehand to patients so they can come prepared. And please just remember that we don't have to have solutions for everything. That's why it's MDT. And just remember that these patients have complex needs. And some of the times we do need to reach out to the specialist team or specialist teams like Maggie's or Macmillan Cancer Support. So I think curiosity and really trying to understand what the unmet needs of the patients are and being open and honest with them to say that I might not have answers for all of your questions, but I will look into it and come back. And over a period of time, you'd have so much information that pretty much most questions you would be able to answer yourselves. And your clinicians, your GPs in your practice are your support resource. So please just reach out to them if patients have physical needs and you're not sure. Someone might say fatigue, and there are amazing leaflets out there that says, this is what you do for fatigue. But then, it could be that there are other medical reasons for fatigue as well. So if there are physical symptoms and you're not sure, just make sure that you discuss this with the clinician who's supporting you, and make sure that I know most of all of our roles do have clinical supervision and support, but if there isn't, if you're doing cancer care review, make sure that you make it explicit to the practice that you need that support. Next slide, please. So a good cancer care plan at the minimum should have these informations. You need to know what's important for the patient, what are their concerns. It's not just enough if you identify that, you have a clear agreed plan with them, that how are they going to tackle this, and what kind of support is available around them. It could even be an appointment with a GP, whatever it is you facilitate for them. So at the minimum, I think a cancer care plan should at least have these elements to it. Next slide, please. So I see that there are things going on in the chat. Please also share your experience of doing cancer cares, the uplifting experience you had, what patients really appreciated, and what their frustrations were. I genuinely think that it kind of helps you to start thinking about things. Solutions are out there. There are amazing websites out there, resources out there. Your template itself has got lots of resources. It's just, understanding what the patient needs and going and looking for those informations and making sure that when they come and speak to you, you give it to them in an accessible form, not that, oh, go to this website and there's a million one links and they don't know what they're doing. Okay, this is my last slide, and I'm going to hand over to Dr. Bunmei, who's going to talk more about screening. Just remember that every healthcare professional, frontline staff, reception staff, when you have contact with patients, there's lots of things you could do to make a difference to people's lives. So there was this campaign, Screening for Saving Lives, and what they recognized was that breast cancer screening saved about 1,300 lives a year in the UK. Bowel screening, 1 in 4 patients, you stop them from dying because you diagnose them with early cancer. Cervical screening, approximately 2,000 lives are saved. That's staggering numbers. And that's based on the fact that our screening uptake is not uniform across the country, and there are areas where screening uptake is really, really poor. So if you were to improve the screening uptake, imagine the impact you would have on lives of people. So I have put a website over there. There are some easy information leaflets that you can give to patients. And I genuinely think that when patients come for cancer care review, we should actively be promoting screening to them as well. I'm happy to take questions at the end. Thank you so much for your patience.
Thanks, Sangeeta. I'm going to literally race through my slides, just because we've got G, and just hopefully we're able to save time for questions. Yasmina, just the next slide. So I'm going to be talking, I'm going to be touching on screening, early diagnosis, just a quick statement on the NHS long-term plan, and really what is happening with the PCN-DES for the 23-24 period, and locally in the NEL patch, and then touch on health inequalities. My name is Bumi. I'm a GP and also a prostate cancer UK clinical champion. So the NHS long-term plan, the ambition really is to up the number of patients who are diagnosed at stages 1 and 2 with cancer. So patients who are diagnosed with cancer, we're picking them up stages 1 and 2. And that number, the aim is to push it up to 75%. So we have 75% of patients who are diagnosed with cancers are diagnosed at stages 1 and 2 by the year 2028. Now, the PCN-DES is kind of working towards that. And what it's touching on is improving referral practices. So if that is improved, you're more likely to get patients early. So clinicians will pick up cancer signs quickly, and the process for patients being seen is quick. Improving screening uptake, and that is working through the PCN, so primary networks, to make sure that screening uptake is improved generally. And we would know about this locally, especially with bowel cancer. There's a lot of work going into kind of improving uptake. The PCN also talks about adopting and embedding the FIT test. So those with suspected bowel cancer, you're doing the FIT test for them, and also adopting and embedding tele-dermatology. And I'll come to that in a short while. There's also a focus on prostate case finding. What's happening locally is there's the targeted prostate health check, and that's being run at BAPS Hospital. And some PCNs might have been contacted outside the BHR area. One PCN I know presently is piloting that in the BHR area. And the aim is generally to catch that cohort of men at high risk. So Black men from ages 45 and above, so 45 to 69, because we know their chances of prostate cancer, it's double the risk with their white counterparts. And then also men, so one is Black men aged 45 to 69, and the second is men generally aged 45 to 69 with a family history of prostate cancer. Okay, next slide, please. So breast screening, it's a screening program for all women aged between 50 and 71 years old. What would happen is women would automatically get an invitation every 3 years. Now, the first invitation might not necessarily come at age 50. So for some women, it could be 51, 52, stretched to 53. But really, if a woman's not had an invitation, age 53 latest, they really should be speaking to their GP. Now, if you have women 71 years and over who would want to carry on with the 3-yearly breast screening program, what they would need to do is contact the local breast screening service and ask for an appointment. Next, please. And for us in the BHR area is the Outer Northeast London Breast Screening Service, and that's in Romford. Is the in-health office in Romford. The other centres are kind of within the Nell patch, but outside the BHR area. The Epping one can be used by Redbridge, really. Next. So what's the eligibility? I've said all women, but also we know we've got trans men and non-binary people. And so if you have a trans man or a non-binary who's been assigned female at birth, okay, and they've not had an operation to remove their breast, either bilateral mastectomy or a top surgery. Top surgery is just generally either augmentation or removal of the breast tissue and kind of changes made to the nipple and the chest wall for trans or non-binary people. So if they've not had that surgery, then they're eligible to have breast cancer screening, and they'll get an invite every 3 years. Also, if you have trans women and non-binary people, so people who are assigned male at birth, but have now started taking feminizing hormones, okay, they also would be eligible for 3-yearly breast cancer screening, and they would really be invited. If a patient is registered as female with their GP, they'll automatically get an invite. If they are registered as male with their GP, however, they will not automatically get an invite. And what they would need to do is contact the local breast screening service. It's kind of what I've shown in the previous slide. Next, please. Cervical screening. So women and anyone who's got a cervix, and it's between the ages of 25 and 64. You may have people register at your practice who've had cervical screening age 22, 21. It's always good to know if they've moved. So Scotland, it starts from age 20, England, age 25. Okay. Now, those 25 to 49-year-olds would automatically be invited every 3 years. And those aged 50 to 64, they will be invited every 5 years. Next. Yeah, so there is a service, again, for trans or non-binary people who are not comfortable having the kind of swabs being taken at the practice. It's the No Barrier service, and that's located in Soho, London. So it's just being aware in case you come across patients, you're signposting them to that service. Next slide, please. Bowel screening, the current age is goes from age 54 up until age 74. Now, it used to be from age 60 to 74, but sometime in 2021, that was April, there was a plan to kind of bring the age down to 50. And that was a move to do that across every 4 years. So presently, anybody aged 54 to 74 will get an invite, and automatically what they get is a kit every 2 years. From May this year, that will move to 50. Anyone from age 50 upwards would be invited for bowel screening, and it's the FIT test, fecal immunochemical testing. Now, that's with screening. I'm just going to move on next to kind of what is happening with the deaths and locally. If you remember, I mentioned kind of really embedding FIT testing and tele dermatology. So I'm just going to touch on that. Next slide, please. So this is a flow chart for the FIT test in primary care. Remember, this is not for screening. This is to diagnose patients. So if a patient's presented with lower GI symptoms. So either blood in the stool or unexplained pain going on, not resolving, or a change in bowel habits, then they would follow this pathway. And what would happen is the clinician, either GP, physician associate, anyone within the practice, AMP, seeing them, request a fit test. And if it's greater than 10, then it will be a referral via the urgent pathway. Next slide, please. Now, touching on the skin and teledermatology, so in the Northeast London areas, just an update. So the NICE guidelines are clear, okay, about how to manage those presenting with skin conditions and if you suspect skin cancer. So there's the 7-point checklist. Now, what is encouraged now is that you're using dermatoscopic images for referral. So it goes beyond kind of just the GP having a look at the skin lesion and kind of, yes, I feel this may be cancer and referring. We're kind of hoping now to move towards a dermatoscope being used in practice or referring the patient to a service where the dermatoscope can be applied. And that's been done in different areas. It's being trialed and it's worked. So Chelsea and Westminster Hospital presently, they have an outreach clinic where patients are referred and they would have a professional photographer who will take a photo of the skin lesion and apply a dermatoscope to the skin. And then using an app called DAM, they just send that to the consultants and the consultants can decide who needs to be seen further or who needs to be discharged. Next slide, please. So what are the NICE guidelines? I talked about the 7-point checklist. And this is generally for suspected melanomas. And you can see on the slide there, you give 2 points to major changes and a point to minor changes. And if you add up your numbers and you get 7 at any time, the chances of that being a melanoma is high. And so you need to refer that patient. So the major changes will be a change in size of the lesion, an irregular shape, or an irregular color. 3 will be 2 points. Now, if you then see the patient and you notice kind of measuring that it's bigger than 7 millimeters, that is a point. If there is inflammation around it, so they come, oh, it's now sore or it's looking red, you give a point. If it's oozing or there's a discharge, that's a point. Or if the patient reports a change in sensation, so it's gone numb or it's starting to get tingly, that will be a point. And if you add it up and it's 7, then you refer. Next. So one thing about referrals for the skin, there's what we call the ugly duckling sign. And you would get some people that have got a lot of moles around their body. Say, for example, someone comes and say, I've got a lot of moles over my back, but I don't know, I just want to check it. I don't know if it's changed or things like that. Now, when you're taking a look at the back as a clinician, what you're looking at is there a mole that looks different from the others? It just looks different from the other moles. And that's the ugly duckling sign. Always be wary of those kind of moles. Again, NICE is saying a dermatoscope should be used in primary care. I think I touched on that, but it should be used by those who've had the appropriate training. So you have to evidence that you've had training. They also encourage, if you're a clinician, you're seeing the patient, to feel the local nodes. So if someone's presented with a mole on their arm, you want to really check their armpit just to be sure that there's no swollen glands. So if you can incorporate that into your practice, that would be great. And for those that do minor surgery, they say really do not biopsy a lesion if you suspect it's cancerous. Next slide, please. Again, just a chart kind of as a guide to referral for the skin. Next slide. So again, update on NEL. Hamlet, Newham, and Waltham Forest area, they've arranged training for salaried GPs on the use of dermatoscope. And that's just trying to fall in line with the long-term plans of the NHS and the DES. Whips Cross Hospital is offering medical photography, as I said, for the dermatology. They're specially trained photographers take a photograph of the lesion, they apply a dermatoscope to the skin and take a photo. So they need special training, and Whips Cross is offering training on that. Our local trust, BHR, is actually trying to pilot that, and I don't know, I think they might already have started, but I'm not sure about that. And then the City and Hackney area, they've actually audited the use of teledermatology. So yeah, next slide, please. Inequalities. Yeah, I did say I'll be rushing through the slides because I've got Gia coming after me, so I don't take much time. So health inequalities, we know it does affect every aspect of the cancer pathway, and that would include prevalence of cancer, especially the risk factors with cancer. So things like smoking, alcohol, obesity, health inequalities impact that significantly. Participation in clinical trials and research, that's another aspect affected. Uptake of screening program, the likelihood of patients presenting early with symptoms, the stage at diagnosis, that is all impacted by health inequalities in cancer. And importantly also, not just the access to care, but also experience of patients with treatment that's impacted in every form of cancer, and that's well documented in the literature. Next slide, please. So talking specifically about cancer inequalities, we know it's regarded as the difference between individuals' cancer experience or outcome. And that difference is as a result of their socioeconomic status, their race, age, gender, disability, religious belief or no belief, sexual orientation, the type of cancer, and actually the location. Recently in the news, they've been talking about kind of things like postcode lotteries, where even in certain areas, your chances of a better outcome following the diagnosis of cancer is higher than if you were in another part of the country. And not just even parts of the country, even if we take the NEL area, I can say, for example, prostate cancer. I know things have improved now, but a few years back, if you were diagnosed in the BHR area, your chances are better than elsewhere. So, yeah. Now, we also know that there's a lower take-up of screening among ethnic minority groups, and that's independent of their socioeconomic status. So there was a study that looked generally at women from minority groups, and it looked at women between the ages of 50 and 70 to look at how they attended screening programs. And you'll be amazed to note that 45% actually never took up any screening program. 45%, which is really high. Next slide, please. So, because of my interest in prostate cancer, anytime I'm talking about cancer, I'm always talking about prostate cancer. And with prostate cancer specifically, we know race generally is one factor. So Black men have double the risk. So it's 1 in 4 in Black men compared to 1 in 8 in white men. And they've got the double risk with diagnosis or dying from prostate cancer or developing it at a younger age. Also, advanced stage disease, what we call metastatic disease, we know is strongly associated with deprivation. So patients in the most deprived areas, they are 29% more likely to be diagnosed late, and that's with metastatic disease. And that graph there, you can see the London area, that's about 12.5%, and you compare that to somewhere like Scotland, or you start moving up north, and you see those diagnosed at late stage, and that's a vast contrast, really. Next slide. This is just a quick slide. It's a slide from America talking about prostate cancer and where race comes into it, but really it's just looking at the common factors. So, and this applies to everybody. So disability, race, gender, male or female. Generally, you have to look at things like culture. You have to look at economic factors. We've just talked about the location where one resides could significantly impact on the outcome with cancer. Participation in clinical trials was what we mentioned also, and then the specific cancer type. Next slide. Research. Research is something I always touch on. So we know that data from the National Institute for Health and Cancer Research has revealed areas within the UK where kind of you have very, very low uptake of research. Now, we know people that take part in research, they're usually older and they're very well educated. That's a common thing with research. The more educated and the older a person is, the chance that they will take up research. Okay, so what we have to look at is those gaps in knowledge and experience, those things that have hampered people kind of taking up research, and really just addressing that. And it's not a discussion for today, but when we have discussions with patients generally, and they say, oh, they've never taken up research and things like that, at least we have an idea of those things that can hamper or hinder patients from taking up research or going into studies. Next slide. So the factors are varied. So we have the socio-economic circumstances, and socio-economic circumstances generally, it's classed in the UK as either low, medium, or high socio-economic states, and that's dependent on one's education, one's income, and the type of job one does, and that can really impact everything we've said about cancer, either presentation, management, the journey from cancer diagnosis, taking up research. It can affect it. Social environmental behaviors. So social behaviors, generally looking at the positive ones like cooperation within groups, or the opposite ones when we look at things like aggression. Okay, and when you look at certain groups, those things are strong factors. If there is better unity, better cooperation, the outcomes are better than if you've got the opposite. Lifestyle choices, strong evidence, really very strong evidence that those with poor diet, smoking, and alcohol, we know those lifestyle things have higher incidences with cancers. Okay, and we know there's the link to the socioeconomic status of the person. If we don't take anything out of today is the bit around smoking. Smoking is it's the #1 preventable cause for cancers. And you'll be surprised to know that less affluent groups, less people from the affluent group smoke. Okay, you get smoking more in disadvantaged groups. So no surprise, cancer cases are higher really in disadvantaged groups. So it's all linked really, and it's the single biggest cause of inequalities when you're looking at death rates. Okay, so if you're looking at the poor and the rich, smoking is one factor that stands out. And then we've got structural inequalities, which is the final bit on my slide. And that's when you look at the system as a whole. If things are not put right, then really there will be strong inequalities. Thank you.
Thank you, Dr. Bumi. So hi everyone, I'm G, Senior Health and Wellbeing Coach. I'm a registered naturopath and yoga specialist, and I'm also trained in the Gerson therapy, if anyone knows about that. I do have some experience in cancer care, critical illness, and end-of-life care. But my role today is actually to share how the personalised care roles can support the cancer care. Now, I'm not formally trained in cancer care reviews, and I suppose my question would be, how do ARS roles, the personalised care roles, access formal training to support cancer care? Because it could be invaluable. Next slide, please. Okay, so the benefits of offering personalized care. As we heard from Sangeeta, it's the reality of recovery, which can include fatigue, feeling isolated, it's the overwhelm, it's a life-changing disease where decisions have to be made. And I suppose as personalized care practitioners, we have time to really explore what matters to the patient and connect them. And I've heard from Dr. Bumi and from Sangeeta that connection is key. So we know social prescribers are really well versed in this and experienced in this to really connect patients recovering from cancer or at any stage of their cancer treatments, to connect them to the social and lifestyle needs, to community resources, to really take the pressure out of appointments and making decisions, and signposting them. Health coaches, I'll come on to that, but it's about setting goals, supporting self-management and lifestyle. A lot of my work when cancer patients are referred to myself as a health coach is really about stress management and motivation, trying to change their mindset from just focusing on the cancer to what life can mean and look like aside from their dis-ease state. And care coordinators are brilliant at care navigation and also for seeing the MDT side of their case. Next slide, please. So benefits of health coaching. The role of a health coach is to support patients to tap into their own resources and their own potential, building their knowledge, their skills, and their confidence to self-manage effectively. And we heard earlier from Sangeeta that information is quite scarce. Actually, there's a lot of information available online, and what usually happens is that patients get very confused as to what's right for them and what's meaningful to them. And so we can take that time to help them process what important information actually means to them. Health coaching is not disease specific, and we will meet the patient at any stage of their complex needs, their long-term condition. And we are experts in person-centered behavior change. So it is all about mindset change and behavior change. So we look at lifestyle, improving activation and motivation levels, helping and supporting patients navigate the health goals, and as well as supporting the clinical team. And there are various factors that we will look at. Next slide, please. On the website, Macmillan website is a fantastic website, and this is often something that I refer to. And social prescribing has got a really good platform there, with a guide for primary care networks. If you haven't seen it, I urge you to look at it. It really encourages the MDT approach. And Macmillan Cancer Support recognises that social prescribing is really essential as an enabler to deliver integrated personalised care for people living with cancer. As we know, 70% of people with cancer also have other long-term conditions, and it has a huge impact on their emotions and other aspects of life. Next slide, please. The holistic needs assessment, this is a great tool. And again, I urge you to look at it at identifying a patient's concern, a patient's needs. There's a lot of information on the website, but generally I'm just going to talk through what I've integrated into my health coaching. It's by meeting the person and identifying what their concerns are in that moment immediately, and really start a compassionate conversation around their needs and what support plans they need, and signpost them to the information at the right time. Next slide, please. A success story I'd like to share with you. I've had many referrals. Most of the referrals are usually due to weight management, fatigue, stress and motivation. But once we start undressing their story, we understand that they are they have experienced or have lived with cancer. This particular patient came in with who had to have a sudden mastectomy a year ago, just after a routine check, and she had no time to process the grief or accepting the diagnosis. It had a huge impact on her relationship, also caused work-related stress, and she was really had low motivation levels, and she was being supported at that time by Macmillan nurses. So the initial assessment was 60 minutes. I saw this patient for 3 months. And really, it was about creating trust and a safe space by actively listening. All I did in the first session was listen to a story, and then decipher what was the most important thing that she needed to support her in her well-being, and what success looked like and felt like for her. So if she could see herself 6 weeks, in 6 weeks' time, what did she want? What did she want to feel like and look like? So we practice present moment awareness to gain some acceptance. So it's about acceptance, stress management, so visualization, mindful techniques, relaxation and breath work, really homing into the spiritual well-being and emotional well-being, identifying the things that mattered the most to her, and really reawakening hope, inspiring her purpose. And she was also looked after by the social prescriber for financial advice and access to union support. The outcomes in after 3 months was that she felt that health coaching changed her perspective on life, helped her gain clarity. She felt inspired with a new purpose. That gave her a new job, less hours, moved closer to family, and really put her in her space of her happiness factor. Next slide, please. So it's all about mindset change. We can't often control what happens to us, but we can control the way we respond. And these are some of the stress management skills that we actually kind of work with patients to address a lot of the stress factors, because a lot of patients will come in with fear as their kind of like common factor. How can we alleviate the fear and help them step into clarity and peace of mind? Next slide, please. And this often helps them make their decisions. And these are some of the things that we talk about: the power of scent, how it impacts our hormonal levels and helps to regulate the nervous system. It's very simple. And I've just put a couple of things there that patients have found really useful: rosemary and lavender. Next slide, please. And fatigue management, rest and restore. So teaching patients how to rest and restore. So there's a body scan meditation that I've shared with you here, and the count of 4 breathing technique. And I've also put a link to the autogenic relaxation or progressive relaxation that a lot of patients find very, very useful. But the benefits of the health coaching is really clarity, direction, increased confidence, life skills, connection. So really overcoming their fears and phobias. Next slide, please. That's it. Thank you very much.
Thank you very much, G, and thank you, Doctors Bhumi and Sangeeta. If any of you have any questions, please don't hesitate to ask now, or perhaps we could also take, oh, we've got some in the chat here. So this is from Muyama. Can you see it, Sangeeta and Bhumi? What support can GP assistants assist you with for cancer patient care?
Yasmina, sorry, I can't bring, seem to switch on my camera. But essentially, I would suggest that you speak to the clinician in the practice. So there is an expectation that there are certain areas that needs to be covered in your cancer care review, and you could discuss with your GP, identify the areas you could do supported by your GP. If you needed a bit of training or supervision, they can offer you that. And I'm sure any practice would really appreciate you taking on this work.
Right. I think there were some other questions in the chat from earlier. If I just go back, lots of suggestions being made. Checklist was spoken about. I don't know if this is a question from Elizabeth Howard. This was earlier. If they have had head and neck tumor, remember thyroid function. I think that was just a comment, wasn't it? If I'm not mistaken. Okay, great. Before everybody goes, please don't go. Stick around. It'll take you literally 5
Hello?
seconds. Oh, sorry.
Can I just say something?
Oh, yes, Elizabeth, sorry.
Okay. I had cancer about 20 years ago. There wasn't social prescribers or anything. The first bit you've got is the immediate treatment. And people go into the immediate treatment and they go, I've got to have chemo, I've got to have this, and it's all focused on the hospital. And it's where you do the time in the cancer care review. You've got to know who's supporting them. And a lot of the time, next of kin isn't, or who's caring for them isn't written down. There's things like I was very fortunate that I had an ENT specialist because I was under the hematologists for lymphoma. So my vocal cord was paralyzed. So it's only through the ENT that I got to see a speech therapist to get my voice back, which took 18 months. Because I was at the Marsden and I was lucky enough to have healthcare at the time. Hello, are we still on? Because I've lost the pictures.
Yes, we can hear you.
I had some of the well-being and the relaxation things. And I think the relaxation thing, at first you think, oh, what's this about? And then you go, oh, well, I may as well. But the relaxation training was very good. How to sort of work through pain and colours and fear. So I think the well-being coach for an hour with an idea, might actually get things out of the person that wouldn't otherwise come, because they know it's a 10-minute appointment with the GP. They're not going to say things, and they know the GP does the medical things. They're not going to say things. The fatigue is a big thing. The mood, they don't always want to go for antidepressants, but the well-being can do it. If they find there's financial things, they can send over to the social prescriber. So with well-being, it might be a gentle way into sort of combing out which direction to send all the medical or non-medical things to. And I've just been to the dentist and had a really deep filling. And I don't take anaesthetics, local anaesthetics for it, which amazes her. The injections. And then I just had local, and she'd say, I'm amazed at how well that local worked on you. I've never seen anyone with that. But it's partly because I can meditate myself down, and I'm not at all scared of the dentist. And it helps enormously with your management of sensations, noise, etc. So when they're coming to difficult parts, the management of pain and fear through being able to do the relaxation is really quite important. And it's something that people don't prioritize because it's not medical and it's not going to cure them. But actually, it helps with the coping of various bits, and that people treat you strangely. And one thing that I did say to the wife of someone was, everyone's going, the oncologist said, oh, well, I hope he might make it through to Christmas. And the GP that was the prime GP looking after this guy with esophageal cancer said, yeah, let's hope we make it through to Christmas. And I looked at this guy. He had lung mets. He wasn't going to make it through to Christmas. And if he did, it was not in a good state. So I actually told the wife, look, Christmas is important to him. Find out what is important to him about Christmas. Is it family? Is it the presents? Have a pre-Christmas earlier in December, a few weeks early for him. And then the family can have the second Christmas on Christmas. He had the pre-Christmas. He died Christmas Eve with his wife quietly. And that's about what's important. It was important for him that the family get together and have a sort of Christmas celebration. And the fact that it wasn't on the 25th of December didn't really matter. So I've said, garbled a lot, your turn. That's it.
Thank you very much, Elizabeth. Thank you.
Yes, thanks, Elizabeth, for sharing your experience. I think one thing we know currently is the role AR staff are playing and will be playing in the future for patients is just huge. And it goes beyond just the treatment. Cancer care reviews, locally we did training for our nurses and advanced HCAs, and that was purely because we know they take the time to speak to the patient. It's not just a 10 minutes appointment. The feedback from patients about nurses is better, and that's kind of the same thing we're seeing with cancer care review. So they are the ones doing it now. They had the training and they're doing it. So that thanks for sharing that. It's not just kind of the medication. It goes beyond that for patients. Yeah.
Thank you very much. There were some questions actually that I just wanted to make sure that we answered. One person has left, but I said that I would make sure that their question was answered. It's by Atia. Yes, you mentioned dermatoscope training. Is this still available?
So it actually varies. The London area I mentioned, they actually organize that strictly for salary GPs. but I know sometime in January there was another training. It was an hour, practical skills. Training, dermatoscopy training happens everywhere, and you get it online also. L'Oreal, that's the dermatological company. I don't know if I've pronounced that right. That's L'Oreal. L'Oreal, they make skin products and things like that. They offer training.
L'Oreal, okay.
Yeah, if you check online, there is a lot of training ongoing for dermatoscopy. But the nail area, there isn't anyone I'm aware of now. Yeah.
There was some other questions. I think one of them was from Fred. Thank you, Fred. Please, can Dr. Bumbi break down a bit more why men from Black communities have a higher chance of having prostate cancer?
That's an interesting question. No, that's so for prostate cancer, there's still a lot of research going on, and Prostate Cancer UK actually have got funding now, and the plan is going ahead to do the biggest such study into prostate cancer anywhere in the world. They're going to be recruiting a huge number of patients, and the funding is there. There's been a number of things brought out in various sectors, but it's just, I feel they're just little bits, little pieces of the whole picture. So people talk about, is it a Black men? If you're talking about androgen, is that a factor? I don't know. I don't think race really matters with that, but they've looked at that. They've looked at genetic predisposition, and that one, there is evidence that there is some genetic predisposition. And there are, I know, I think it's the Marsden, they are looking at genetics in men diagnosed with prostate cancer or their close relative. So it's not just looking at things like the BRCA gene, or for example, if you're talking breast cancer and certain groups of Jewish women, that risk is there. Then going further to look at the prostate now to say, are there certain genes that puts one at higher risk of having aggressive prostate cancer? So it's a number of things. I don't think there's one clear answer, but those things I've mentioned are part of what's been looked into.
Thank you very much. I believe that's all the questions. Oh, someone have a question? Great. Wonderful. Thank you to all of you who have filled in the survey. I will now stop recording.